See through the optic nerve, save sight, save lives. Our eyes are a window to our brain, and as ophthalmologists, examining the optic nerve is impertinent in our practice. The nerve can present to us as deceptively normal with edema or as atrophy with pallor. Evaluation starts with visual acuity, color vision, particularly color desaturation, contrast sensitivity, examination of the pupil, and fundoscopy. Visual field tell us about the function of the optic nerve, while an optic coherence tomography can tell us the actual structural loss. An ultrasound B scan of the optic nerve head and the MR imaging of the brain and the orbit can give us further information of the pathogenesis. A normal appearing disc can confuse us in a patient with decreased vision, abnormal color vision, or a reduced contrast sensitivity. Presence of RAPD in such a setting could give us a clue to either a retrobulbar neuritis or a posterior ischemic optic neuropathy, which can be missed otherwise. Let us now discuss about disc edema. This can present either with no visual loss, acute visual loss, or insidious loss of vision. If a patient comes with no visual loss and the disc looks edematous, we have to first be sure it is a true or a pseudo disc edema. So let's understand the difference between a pseudo versus a true disc edema. In pseudo disc edema, the elevation is confined to the disc. The disc vasculature is visible at the margin with no venous congestion. There is a sharp crescentic peripapillary nerve fiber layer reflex and no exudates. While in true disc edema, the elevation extends into the peripapillary retina as is shown by the blue arrows. There is a graying and muddying of the peripapillary nerve fiber layer and obscuration of the vessels. Coming back to this pseudo disc edema, where on B scan shows calcific appearance, positive on fundus autofluorescence, and confirmed on CT scan that this is a disc drusen. Similarly, in this kind of a disc, looking at the refractive error, we can say it's a myopic disc. Now, disc edema due to diabetic papillopathy will have additional features of diabetic retinopathy, could be unilateral or bilateral but asymmetric. Central retinal vein occlusion can present with disc edema, which is unilateral, and a typical tomato splash appearance as is seen. Now, presence of acute vision loss can occur in patients with optic neuritis due to demyelinating disorders like multiple sclerosis or ischemic optic neuropathy. Differentiating between the two is a must. While a visual field assessment in AION commonly is altitudinal, imaging of the brain shows a contrast enhancement of the optic nerve, periventricular opacity in multiple sclerosis. Additional systemic workup to rule out ischemic risk factors is a must. Other causes of demyelinating could be neuromyelitis optica or MOG-associated disease called as MOGAD. Some patients may give a history of gradual loss of vision with an insidious onset, which could be because of compressive pathology like an intracranial space-occupying lesion or an infiltrative pathology. So, when a patient presents with unilateral disc edema and is under 40, suspect optic neuritis. If older, ischemia could be our first differential, which is associated giant cell arteritis, and if present, confirming an arteritic AION. If not, it's a non-arteritic AION, which is our diagnosis. An optic disc edema with macular star should also be suspected in presumed ischemic optic neuropathy. If we consider compressive causes, an MR imaging can demonstrate a structural lesion. If not, suspect an inflammatory or infiltrative cause, provided we have ruled out trauma, and relevant investigation should be done to rule out toxic or nutritional causes as well. If it doesn't fit in either, it could be hereditary like Leber's or then unexplained disc edema, which is a diagnosis of exclusion only after all other investigations are deemed negative. Bilateral disc edema needs to be dealt with in more detail and can present with no to profound vision loss. When there is no vision loss with bilateral disc edema, again, rule out a pseudo disc edema due to drusen or an early papilledema. Hypertensive retinopathy can present with disc edema of various grades, including malignant hypertension. Therefore, in all cases of bilateral disc edema, always check the blood pressure in the clinic. It can prevent a catastrophic systemic complication if timely intervention is done. Papilledema is one of the most common causes of bilateral disc edema and is associated with raised intracranial pressure. Early papilledema can present with normal visual acuity, normal visual fields, and only a mild hyperemia of the disc margins. But there's absence of induced pulsations, and that is pathognomic of papilledema. In established cases, distinct features are severe hyperemia, moderate elevation, indistinct margins, loss of cupping, and fields may show an inferonasal step or an enlarged blind spot. The role of ultrasound B scan in papilledema is unparalleled. presence of a crescent sign showing the subarachnoid fluid around the optic nerve head, telling that it is basically this SAF that is due to a raised intracranial pressure. And OCT of the optic disc can also help to differentiate a disc drusen from a true disc edema. A chronic case of papillary edema, on the other hand, may present with visual acuity that could be minimally or markedly reduced, a definitive disc elevation, presence of optociliary shunts, pattern lines may be present too, visual fields begin to constrict and could be mild to severe vision loss, and eventually central vision could also be affected. In later stages, once atrophy sets in, the optic disc shows pallid edema with profound vision loss, and the disc starts appearing flatter, which is a false sign. Any case with papillary edema, investigation that can clinch the diagnosis. To treat a case of papillary edema, multidisciplinary approach is required. The cause of the raised ICP has to be dealt with by prompt referral to a neurologist. It can be treated medically or surgically, and optic nerve sheath fenestration can salvage vision and provide a much better quality of life in such patients. We prefer a medial transconjunctival approach, wherein the medial rectus muscle is disinserted and the optic nerve sheath is identified, followed by a small nick made, letting out and then making a fenestration. To summarize, bilateral disc edema, once confirmed as a true disc edema and if present with vision loss, should be further investigated for the cause. MRI can give a clue to the structural lesions if present. If not, a lumbar puncture showing elevated CSF pressure needs to be treated as papillary edema. If the CSF pressure is normal, other causes should be looked for. Unlike disc edema, the mystery surrounding the optic atrophy is harder to deduce. A pale disc can manifest in various forms. Temporal pallor can occur from toxic or nutritional causes or as a result of optic neuritis. Optic neuropathy due to toxicity of ethambutol is well known and is associated with bullseye maculopathy. Your history of treatment for tuberculosis is a prime key in determining the cause. Optic atrophy with cupping can be seen in ischemic causes or due to compressive pathology like a pituitary adenoma, where the loss of macular GCC corresponds to the visual field loss and MRI brain is diagnostic. Remember, both of these are not pathognomic of a specific type. Presence of arterial attenuation goes in favor of ischemia or LHON having a poor prognosis. A bow tie pattern of pallor is characteristic of involvement of the contralateral optic tract. Presence of peripapillary gliosis is seen after resolution of papillary edema, that is secondary optic atrophy. On the basis of the visual fields, a central or a centrocecal scotoma is common in toxic or nutritional causes. Ischemia such as AION can present with altitudinal defect. Hemianopic field defects are suggestive of neurological or compressive lesions in the brain, which could be heteronymous in chiasmal lesions, while those of the optic tract showing homonymous defects. Now, let us put this knowledge into practice. A detailed history, a thorough evaluation and appropriate investigations with prompt referral will lead to early and better diagnosis and treatment. It can not only save sight but save lives too. Thank you.